It is a hard question to answer. When do you take a tooth out or when do you try and save it? So I'll try and explain by using two case studies. The first case study was a patient that presented in extreme pain on the lower left first molar. The patient didn't have a high dental IQ or any motivation to have a tooth saved, but unfortunately he had to deliver a speech that evening at a function, so removing it wasn't really possible, and that's why I decided to remove the post only. Believe it or not, this was stable for 15 years before it started to cause this extreme bite sensitivity. Removing the post and draining of the pus, it is gross, but it's such a lovely feeling to have that infection out of a tooth. Immediate relief of pain, we gave the patient some oral antibiotic and we left it to keep on draining. We left it open for the next 48 hours until we could schedule an appointment for extraction. I took out the roots in a minimally invasive way by splitting a tooth apart. As you can see on the next image, the top root bang in the middle of the root if you follow the vertical and horizontal axis. The next patient was highly motivated to save the tooth. She had a history of a failed implant in the position of the 4-7 and also extreme bite sensitivity on the 4-6. The preoperative shows that the placement of the post seemed to be fine, but destruction of the lamina dura on the distal root in the furcation area as well as at the tip of the distal root was evident. This case was done before I had access to live video recording or intraoral imaging. Removing the post also caused the same type of draining pattern of pus from the distal canal that we saw on the previous case. Now, I had my doubts about this case. I thoroughly informed the patient about the labor-intensive nature of the procedure, but she literally begged me to try anything, so we gave it a go. I wedged in a finger spreader in the remaining GP of the distal canal and packed the MTA around it because the MTA didn't want to remain in position without some form of support. We left the finger spreader under the temporary filling to give the MTA time to set and recalled the patient a couple of days later. I carefully rotated the finger spreader to dislodge it, and it left us a nice little path to access the rest of the root with. Patency was established. I do agree that the position of the distal apex seems odd, but it is bang in the middle of that little area there. I wasn't completely reckless. We placed a temporary crown with a permanent cement and monitored it for about 8 months, after which the patient requested we place a permanent crown, which we promptly did. This is, I think, the 8-month follow-up, and this is the last photo I have on record, which is 16 months post-operatively. At this point the tooth settled down nicely and the bone has filled out again. Considering all the factors that plays a role in the decision whether or not to try and save it, in my experience at least, I think the biggest factor would be patient motivation and patient cooperation. Thank you for watching.